All right, so let's get started. I want to thank you all for being here. My name is Jenny Taylor. I'm on the clinical mental health counseling track, and I've been a part of CSI's Social Justice Committee since my first semester here. It's been such a wonderful group to work with. And I want to introduce our special guest, Maria Gambino. She is a licensed mental health counselor in the state of New York and works in Manhattan as a counselor specialized in eating disorders. Maria, thank you so much for taking your time to join us. And throughout this, if anyone has any questions, feel free to raise your hand or just drop a question in the chat. Yeah, all right, let's get into it, Maria, if you are ready.
Ready.
All right, so first question, how prevalent do you think body image concerns are in the counseling profession?
Okay, so when people say body image, they don't realize that it's not just body, weight and shape and percentage of body fat. So I think it's a lot more prevalent than people realize. I would say almost all of my clients, and just so you know, my private practice is only about 50 to 60% people with eating disorders. So even in my clients that don't have eating disorders, there are body image concerns, and that, is acne, right? I have a client with alopecia, right? So she doesn't have hair, and that affects her, body image and height, right? I have a client with cerebral palsy. Mm-hmm. So there's a lot of, there's scarring. I have someone that got bit by a shark, right? And has a big scar, and it affects their self-image and ability to socialize and withdraw and all of that. So just, balding and for men. So there's a lot more body image concerns than people realize.
Mm. And so how can practitioners assess issues with body image?
So when you're with a client that has, poor body image or a body image issue in general, they're probably going to talk about it a lot. It's going to be in their commentary, right? Especially with eating disorders, there's going to be a lot of talk about what they ate, right? Or a calorie situation, or maybe the use of an app, right? Like MyFitnessPal, or keeping track, or getting caught up in this kind of talk. It's going to maybe be apparent, right? Some other ways to assess, you might see visible cues when people have eating disorders. Right? If someone is inducing vomit, they might have, knuckles with teeth marks or rawness. Sometimes when people vomit, they get puffiness in their face here, like a bloated situation by the jawline. And there are signs. Another thing is you can just ask your client, right? What is your relationship with food? What is your relationship with dieting? What is your history, right? What was it like growing up around the dinner table? These are all kind of stories. I have a client who had a grandmother raise her who forced her to eat because they were right at the poverty line, and hungry or not, she was forced to eat. And that kind of disrupted her ability to follow her inner cues as an adult. She eats because that's what you do, not because she's hungry or full and all of that. So just being curious, so looking for physical signs and being able to ask, right?
Yeah. And so you mentioned, like how you're raised and people around you and their influence in your body image. So what other factors contribute to eating disorders?
So eating disorders, they say there's 3 factors, right? One is genetic, right? So family history. You grew up with a mother dieting all the time, or a father who's in the gym all the time because maybe he used to be obese as a kid, or there's talk about it in the house, right? So there's that. There's also, maybe genetic hereditary stuff about, hunger and the chemical imbalances around appetite, hunger, satisfaction. Things might, medically be genetic. Then there's the social stuff, right? The world we live in, the ideals of beauty in our society, right? The normalization of the diet culture, right? Do people speak in terms of fad diets? It is, people don't flinch. That's just part of the world we're in. And negative body talk has become normal, right? People aren't shocked to hear it. That's the norm. And marketing, social media, being able to compare, on Instagram and whatever. So all of the societal stuff, and then there's the psychological component, right? We're all born into this world with different temperaments, different traits. Some are more, type A, and the perfectionistic traits. Those are the ones that are more susceptible. People that have low self-esteem or low worth or have a history of trauma or abuse, right? Or people that have challenges with expressing emotion, right? So put it all together, and these are going to be the people more susceptible to developing an eating disorder.
Yeah. Going off of that psychological contributing factors, what are some common comorbidities you see?
A really popular one, right, is OCD. OCD lends itself perfectly for having an eating disorder, keeping track of, numbers and the calories in, calories out, and getting caught up in compulsive exercising, right? So perfectionism, eating disorders are under the umbrella of anxiety in general. So the PTSD, right? Any other anxiety disorder, phobias, social phobias. I said PTSD is also under the umbrella of anxiety. Borderline personality disorder, there's a lot of impulsive behavior, right? Their mood disorders, right? When you're stuck in the mental prison that is an eating disorder, it's very depressing. Major depressive disorder, bipolar disorder is one as well. But perfectionism, like perfectionistic personality disorder, right? It lends itself very well to an eating disorder where there's black and white thinking, good food, bad food, rule follower, good girl, good boy, being perfectionistic. These are all related. Substance abuse and alcohol abuse as well.
Oh, yeah.
Right? Another common comorbidity that people don't realize is kleptomania. When someone is getting the thrill of stealing, right? Accumulating a lot of stuff with no consequence, right? It's that same kind of pattern with bulimia. I can eat all of this and then just get rid of it, and there's really no consequence. Now eating disorders, they're like addictions also, right? There's the reward pathway of the brain that gets activated when someone is on a high from eating or from starving or from the preoccupation that is, counting and keeping track and strategizing. What am I going to eat? What did I eat? What does that mean I can eat? All of that preoccupation in the brain is, you might as well be high, right? On any kind of substance, because you're not there, right? So this reward pathway of the brain that gets activated from addiction, right? Or gambling, sex, internet. It's also very much the thrill when someone is binging. So it's all related. Or shopping, when someone gets away with theft, right? It's that same kind of high that they can get addicted to.
Wow, there's so much more to it than I knew.
Yeah, shopping addiction is another one. Right? It's compulsive behavior in a lot of different departments, right?
All right, switching gears a little bit, bringing it to the pandemic, which we are all still very much in. What impact did the pandemic have on eating disorders?
Well, the first thing I'll say is NEDA, which is the National Eating Disorder Association. They received 40% more calls to their helpline in the first year of the pandemic, right? So eating disorders also for teenagers specifically skyrocketed with the social withdrawal from friends and the heightened ability to be on their phones, comparing social media, all of what, there was a crisis with teens and eating disorder development, suicidality, all of that, depression. But, I've had clients with binge eating disorder that all of a sudden were home alone with their refrigerator, right? All of a sudden, it was just the companion. I always talk about food wearing many hats for people. A companion, a lover, we derive pleasure from eating, right? An entertainer, so all of a sudden, when people needed more comfort, and their fridge is right there and their pantry is right there and there's no one to stop them and it's a scary world, there was a lot of social isolation. And it really did exacerbate eating disorder patterns for people. There's been a lot of relapses. A number of my clients have had relapses during the pandemic. And isolation also led to depression, right? And then we're depressed, and how do we cope? Our eating disorder behaviors. So then people get stuck in a cycle. Another thing that's interesting with the pandemic is, people before the pandemic with eating disorders would find food shopping to be a stressful event. All the decisions to make. Someone with OCD and anorexia being forced to go and buy food for themselves, they are already faced with a lot of challenges and stressors of reading calories, reading them again, checking them, fearing them, and then adding into the mix a fear of a virus and wiping down, groceries. It was just an additional barrier for people that were already scared to go food shopping. The other thing is there was talk of food shortages, right? And it was a scary world. So people would be buying, cans of food or processed things or things that they would normally get, or fear foods, or if we're home with family, like teens, there might be more of those foods around the house that would scare them, right? The other thing is people lost jobs, right? So finances were an issue. People weren't able to buy as much in some cases. Or would have to buy different things or get out of their comfort zone, right? There's a lot of habituated behavior where people find their safe foods, their good foods. Sometimes there's even orthorexia, which is not in the DSM, but it's recognized in medical communities. Orthorexia, which is a preoccupation and a fixation and obsession with eating purely organic only, right? Vegetables or whatever, supplements, whatever they would need, more expensive things. So there was a big disruption in people's daily routine, right? And depending on where you live, some people weren't able to go to the gym as they would have. There's an exercise addiction. Some people with bulimia, for example, some of their compensatory behaviors, it's not just vomiting, right? They would be needing to purge their calories through exercise. And in the cold winter days, or when there's a curfew and you can't go out after work and their long runs or their gyms are closed, people would be doing 1 million push-ups and sit-ups in their bed because their routines got disrupted. That kept their eating disorder very much alive. So there was a big, there was a big rupture for people. How are they gonna, how's the dust gonna settle for them? And what, the maladaptive behaviors kind of changed for some. Loneliness, right? Depression and the binge eating. People talked also about the pandemic 15 as a joke, right? Where normal people without eating disorders were gaining weight because we're all locked up at home. So you can imagine, right, how this particular group of people have been affected.
Yeah, sounds like the pandemic really exacerbated everything.
Yeah, there were more hospitalizations for eating disorders and longer stays as well for eating disorders. And the other thing I want to mention, some people that need a higher level of care for eating disorders would go to residential programs. And residential programs were also at a loss of how are we going to navigate this strange world that we're in, and some programs would admit less people to have more social distancing. And so less people were available, less resources were available for people. The other thing is people were scared to go into these other places with the germs. And so they might be delaying their treatment until, COVID goes away or things lessen, or we see where we're at in a number of months or whatnot, right? So, and the other thing, some people were home. On the flip side, I will say some people were home and were more able to be monitored, right? When you have a sneaky disorder like an eating disorder and you live alone, you can get away with a lot, skipping meals, right? Or the compulsive exercising. But when you live at home with parents and dinner's on the table and there's no sports and there's no play dates and there's no whatever, it can be also more visible what's going on for someone.
Did you see an influx of patients for you during the pandemic?
I did, but I did a lot of referring out, right, during the pandemic. During the pandemic, I had a baby, I was less available, right? I had a full private practice to begin with. I was just coming off maternity leave. So the calls came in more. I wasn't really able to take on more. So I didn't feel that, that overwhelming workload like some of my colleagues did.
Yeah. So tell me about some common myths surrounding eating disorders and the truth behind them.
Okay, so some myths. Well, one I alluded to, anorexia is the most serious one, right? So some people believe if you're emaciated and you're in the headlines with your baggy shirt, like celebrities and like that, that's what an eating disorder looks like, right? Eating disorders can be any shape, any age, any size, any race, any gender, right? So any sexuality. So that's the first one, or that eating disorders are, like that anorexia is the more lethal one. It is one of the, if not the most, but I think opioid addiction might beat it. But anorexia is the most lethal of all psychiatric illnesses. But a very close second, almost equal, is bulimia, right? And when you're purging chronically and consistently, you are really, affecting your body. You're having electrolyte imbalance. You're having, organ failure, and fluids are all right, messed up, and blood count. And so anyway, people die from bulimia. When I was in my training, there was a documentary done by a mother who lost her daughter to bulimia. And it was, I think the name was Someday Melissa, and I recommend it. But the woman was trying to highlight that bulimia is equally dangerous, right? And don't, think that it's just anorexia. Obviously anorexia, someone is being starved and malnourished. It's a slow death, right? They're slowly shutting down their organs, and their blood pressure, everything is coming down, and their blood count and their blood pressure and their heart, arrhythmias, the heart, but people have heart attacks from throwing up, from the imbalances. So anyway, that's a huge myth. Also, there are eating disorders not otherwise specified, right? So if people don't perfectly fit anorexia or bulimia or binge eating disorder, and they're in this other group, they're equally dangerous. So I think if someone doesn't fully qualify for one or another, the more popular ones, that they feel maybe that it's less of a thing to worry about, or that it could be taken less seriously. And that is not true, because all of the disorders, right, they're all very dangerous, and they're also very slippery slopes, because one traumatic event, one stressful event, one pandemic, something that wasn't quite qualifying as a full-blown eating disorder recognized in the DSM is, now you're kind of gripped by it. So also eating disorders, people don't realize that you can go from one to another, and you can kind of, take turns which one you're doing at any given time, depending on what's going on in your life, right? Or if someone, works on recovering from an eating disorder, but then their alcohol intake goes up, right? Was the root cause really addressed? So, it can go in and out, and you can slide from anorexia to bulimia. There's also different types of anorexia and bulimia. Other myths, some people feel like just snap out of it, right? Enough is enough, just eat. How hard can that be? People don't realize that they are gripped by the mental prison that is an eating disorder and is not their choice. That's another myth, that it's a choice, right? Like, okay, just get over it, just eat, or it's only 5 pounds. She thinks she's fat, or, right? And it's not really about that. That's another myth. It's not about food. It's not about control, right? This is emotion dysregulation disorder. This is a disorder of anxiety. This is a disorder of, anesthetizing feelings and trauma, hidden traumas that are not looked at, or, these disorders are not about food, right? The other thing is, you can't look at someone and tell if they have an eating disorder. Only 6% of people with eating disorders are below a natural normal body weight, medically underweight. So that's only 6%. So most people, the most common eating disorder is binge eating disorder. And most of the time when people have binge eating disorder, they are overweight, but not all the time. So that's another thing, right? Another myth is some parents or mothers specifically believe that it's their fault, right? Had I give my daughter an eating disorder or whatnot, right? Or if someone has a son or a child from a different gender or sexuality, that they're less concerned because they believe it's a little white girl problem, really. And so, yeah, also eating disorders, right? Like I said, are for all races and all sizes, everything, all sexualities. And it's really, I'll get into that in the last question, but that's, I think, one of the biggest ones, right?
Yeah. So how do you help clients become aware of their unhealthy thinking behaviors around food and weight?
Usually they have an inkling that something's not right, right? There's usually, a neurotic thought patterns that are easy to detect for the client themselves, but eating disorders bring with them cognitive distortions. So there is a lot of, looking for evidence, talking to them, and this is CBT, really challenging thoughts and beliefs. Also seeing where they came from, more of the psychodynamic work of trying to understand what drives their behavior, where it all originated from. But it's part of, every session is uncovering the healthy pattern, the unhealthy pattern, so that they are aware of them as they're happening. And I wouldn't need to call it out. It's something that they can detect on their own at a certain point, right? So I talk about it as, a healthy voice and an unhealthy voice, right? Or higher self, lower self, or, eating disorder voice, healthy voice, right? So people have to get good at detecting which voice it has more power, right? And the whole goal of therapy, I say, is to strengthen the healthier voice so that it's the more prominent one, right? And that's why, when people, another maybe myth is that people, it's a little bit of a elusive topic. Can people recover from eating disorders? Can they be cured, right? Some people argue yes, some people no. Kind of like addiction, right? Can you just have to abstain for life, or are you still always an addict, or how? And it's not, there's no real answer, right? It's case by case. People, I opened up that I was a child and had my own eating disorder as a teen. I feel very much recovered. But what I will say is, do some of the thoughts enter my brain, right? On a very, very, very low level, to a point where I can just, I remember that, right? So does that count, right? Do you know what I mean? So recovery is a myth too, where people feel it's just a little bit of a gray area, right? But I think I lost my train of thought. What was the question you just asked me? So I can try and get back to that.
How do you help
the healthy voice and the unhealthy voice? So what I always say is, the goal is to make your healthy voice be the more prominent voice, right? And that the eating disorder voice might never go away, but you'll learn to roll your eyes at it. It won't, steer things for you anymore.
So going along with that healthy voice, and you mentioned CBT, what does a typical treatment plan look like?
So typical is hard to answer because every eating disorder is so different. But the first step is always to assess someone's need, right? The level of care that they need based on their medical status, right? Because they're such dangerous disorders and kind of invisible disorders. There's things going on behind the skin than people realize. So a doctor needs to be involved when people have eating disorders. So setting up a treatment team, but even before that, assessing someone's level of care, right? So that some people have, their vitals really need to be monitored, but minute to minute, right? And so they might need to be in a hospital for a bit, an actual hospital stay, right? So that's one level of care. Then there's a residential program, right? Some people need to live at a place for a month or 2 or 3 and do the wraparound services that are available to them, where there's a psychiatrist and a nutritionist, and there's yoga, meditation, there's group therapy, there's meal planning, meal cooking, meal support, all the stuff, right? To help them get to another level. When they're discharged, then there's another level. There's intensive outpatient, where there's day programs or night programs where people after work can go to their groups and have dinner with other people with eating disorders and be monitored and have all the group therapies around that and meal support with nutritionists and whatnot. And then there is outpatient, which is what I do, which if someone is at the level where they can receive 45 minutes once or twice a week of outpatient just psychotherapy, then, so I do it when I do an assessment and someone comes to me, I first have to see if I'm the appropriate fit for them based on what they need. And then if they are, I set up a treatment team. I need my clients to also be seeing a nutritionist, a doctor, and also a psychiatrist in some cases. So setting up a team, because you really cannot treat this alone, and you really cannot treat this if you don't specialize in eating disorders because of its unique nature and the dangerous quality of them. And then, we go into, there's a lot of psychoeducation. People sometimes don't have any clue why they're stuck in this mess, or they blame themselves, because people usually with eating disorders, and I might be generalizing here and there, but usually we see that they have high standards of excellence out in the world, A+ students, right? Especially people with anorexia, and also they're very hard on themselves. So they might feel that it's their fault that they've gotten themselves into this mess. So psychoeducation is usually the first step to understand what went wrong, right? Out of these different factors, what contributed to your specific eating disorder? What is the main issue, right? The other thing, psychodynamic therapy is very useful in helping detect what happened in childhood, right? A lot of people with, for example, with anorexia, from a psychodynamic framework, it is someone's desire to become prepubescent, right? Because when they are losing their periods or looking like a little child, boy or girl body that hasn't developed yet, and they're rewinding their development in a sense. They are symbolically asking for nourishment, for care, for attention, right? For things that maybe they didn't get that they need. And it's one big manifestation of asking for it, right? So we have to talk about, what are people hungry for, right? Not just food. Like, what are you hungry for in your life? Like that you're doing this whole symbolic kind of expression with your health and your body. So also, low self-worth needs to be addressed, low self-esteem, because when people, there's also a lot of self-loathing or self-hatred, right? Where people, if they don't care about themselves, they don't love themselves, right? They're going to self-destruct too. And that's also what anorexia or bulimia or even binge eating disorder helps people do, right? So CBT is the most evidence-based way to treat an eating disorder. I don't practice that way, where I have 20 sessions for 50 minutes, and we do an organized treatment plan. You can go to CBT centers and do kind of this, it's like a shop of come in for 20 sessions and then we'll see where you're at, and then maybe come in for another 20. I do more ongoing, 3 to 5 year people where, the longer you're in an eating disorder, the longer it will take you to get out of it. So this slow and steady process of healing from an eating disorder. So, the other REBT is also, understanding people's core self-beliefs, right? Sometimes people were bullied when they were younger about their body, or about anything, and they got disempowered, right? Or their self-esteem and their body image got really damaged early on. And from one little incident, one time in school, they could have downloaded this message to themselves of I'm not adequate, right? And then they run with that, right? Subconsciously, and operating in ways that would show that someone doesn't believe they're adequate. There's a lot of people-pleasing behavior with eating disorders, right? When you're anorexic, for example, and this is a general sense, there is a loss of oneself, right? This idea of going backwards with development, it's where you don't have a voice anymore. And it's when you are basically saying, I don't have needs, might need my body to function, and I don't have needs. And so they're not going to be very assertive. So there's a lot of assertiveness training that goes on in my work with clients with eating disorders, helping them empower themselves and stick up for themselves. But even first finding a reason to, if they don't care about themselves, or they hate themselves, or their worth is, there's such low negative evaluations of themselves. So even getting them to a point where they want to assert themselves is the first step. But assertiveness training is something. So my answer to you about, what does a treatment plan look like? It's really like getting clients to feel their feelings ultimately, because they're so busy, like I said, anesthetizing from what's really hurting them. There's a lot of traumatic events that happen in people's lives that they don't look at, they run from. And that's a lot of dissonance within one person if they went through something and they can't look at it. And so then they're running from themselves. And how do you do that? You can't. You have to really be not present in your mind. So the preoccupation, the obsession, all of the things that go on in an eating disorder's brain is very useful in avoiding something haunting them from their past, right? So one of the ways I treat clients is just we start letting their authentic selves emerge, right? What is the real truth, right? And also seeing clearly their parents, their childhood, what happened to them with psychoeducation. Family therapy is also important, especially for the younger people. Eating disorders are more prominent in teens and 20s, but they're not only, right, for that. So when a teenager has an eating disorder, involving the family is kind of important, right? There's a method called Maudsley method that was originated in England, and it essentially means that the parent doesn't let the kid have an eating disorder, in a sense, where they're kind of supervised around the clock, where it's like, look at the time, sit down and eat, right? You're not exercising, you're not doing this, you're not doing that. It's like you're not allowed to have an eating disorder with the kind of around the clock supervision that goes on, right? To just get them medically stable, or to kind of snap them out of it, kind of like nipping it in the bud, because that is the breeding ground. The teenage years, childhood, it starts breeding. So, and like I said, the longer you're in an eating disorder, the longer it will take you to get out. But if you start seeing the signs, to try and just, and have the wraparound support with family therapy to see why this child is starting to, develop in the first place. So, these are the treatments, the various treatments for eating disorders. There's also, yoga and meditation and mindfulness that has been, growing in recent years as a part of an effective part of eating disorder treatment. They've added them to facilities, residential facilities, intensive outpatient programs. The other thing that I work on with clients is intuitive eating, right? So there's a book by two dietitians that kind of revolutionized things for eating disorder treatment. And it's called Intuitive Eating. That's the name of the book, a revolutionary program that works. And anyway, people are so disconnected from their hunger and their fullness cues, right? They eat based on their cognitions, what they're allowed to eat at what time, and the rules, and the good foods and the bad foods. And that's how they go. Versus, am I hungry today? If I am, what number on a scale of 0 to 10 am I hungry? When I start eating my meal, is my number creeping up, right? What number am I when I stop? To get back in touch, right? When you're a baby, you cry when you're hungry, and you might push a bottle away when you're full, and we've lost that ability as adults, right? So getting people back to basics, to feel, right? Feel their feelings, whether it's trauma, loss, an event that happened that they need to process, and also physiologically about what they're feeling in their body as far as hunger and fullness, and also what they're craving, right? And there's also some, somatic work that I do, right? If someone is having an emotional experience in front of me, I might then say, where do you feel this in your body, right? Maybe there's a tightness here. Just body reconnection is very important, because when you have an eating disorder, you kind of reject your body, you abuse your body, and you're just kind of lost up here. So, and that's where mindfulness, mindful eating is a tool that I use with people, where you are engaging all 5 senses while eating something. The smell, the texture, the temperature, right? What it feels like in your mouth, what it feels like going down your esophagus. Can you really hone into all of that? Because that's the opposite of eating neurotically in a binge, right? So to kind of strengthen all of these skills. Another thing that's very common with eating disorders is enmeshment with family members, especially a parent figure, especially a mother figure. There's a lot of daughters and mothers that are enmeshed with eating disorders. And that really means that it's hard to tell where one ends and one begins. And because when someone has anorexia specifically, there's a loss of a voice, a loss of needs. They're just kind of people pleasing and they blend, and then their mom, and there's no boundary, right? Between who is this child and who is this person, right? And that's another thing when I'm working with my clients, I make a joke that you're like, what age were you when you were traumatized, right? What age are you emotionally? Because, this big person in front of me is not my client, right? So we have to kind of go back to where someone started to lose themselves.
Wow. So you mentioned earlier that, you should not treat this if you're not specialized, right? So how did you acquire the necessary training?
Okay, so after I graduated, I needed to get my license. So during my training, the 3,000 hours I had a clock, I was able to get my hours for my limited permit and all of that at the Institute for Contemporary Psychotherapy. So right in Lincoln Center, there's an institute to train people and treat people on a sliding scale. So it was a win-win. And there was different divisions. And one of the divisions was called CSAB, the Center for the Study of Anorexia and Bulimia. And I did their 2-year training program, right, to graduate as a specialist. And during that time, I was required to do my own therapy, right? And I did other activities there too, such as, event planning for like NEDA week and being on different committees, on the advisory board and the executive committee, junior committee, all of what helped organize this. I got involved in all of it, but also was clocking my hours while I was also doing intakes. So I was answering the phone when people would call in, needing to be screened for an eating disorder. And then I was an intake worker, so I was able to match people up with therapists. So I got a lot of experience, and it was a didactic 2-year program where we had coursework. There was a tremendous amount of reading every week, different styles of therapies. I didn't mention this earlier, but DBT, right? That's also a very important style of therapy in treating eating disorders, especially, binge eating disorder and bulimia and distress tolerance and all of that. So we would have guest speakers come in and teach us. We also had nutritionists come in and medical doctors come in, because most doctors don't have any training in treating eating disorders. And just like you're saying, in your school, it's not there. It's not there in the world in many places. And it's a huge feat trying to find a good doctor in the eating disorder world that I want my client to see, because doctors miss signs all the time. Same thing with dentists. We had a dentist come in and talk about the oral health of someone with, let's say, bulimia, with all of the acid coming up on a daily basis, right? With the eroding of the teeth and the enamel and everything that goes on, all the signs. There's something called a halo effect, where it's kind of see-through at the bottom of your teeth. Anyway, these are things you wouldn't think of, right? Yeah. So I did a 2-year program, and I was exposed to all these different, modalities and insights, and so a certification program, right? That's what I did. And now I have a group of women like myself that graduated from the program. And I know one of your questions is about my supervision. I haven't had any trouble finding supervision, because the whole time I was in my program, I needed a supervisor, someone that specialized in eating disorders as well. And so between that and my little group of women that went through the program, we're all very savvy on this topic, and it hasn't been an issue for us. But, you know, if I didn't go through this program, it would be, I would imagine.
All right, so at Montclair State University, our counseling program utilizes a multicultural counseling and social justice framework. So where our identities impacts the status within the counseling session between the counselor and the client. So tell me about your identity as a white presenting cisgender female and how that informs your clinical approach with clients who are both privileged and marginalized in their identities.
Right. You know, this is a touchy topic. It's a sad topic because there's a big problem, right? You know, in just the founding fathers of psychology in general are white men. There's a white supremacist thing going on here about the idealized body type, right? Where it's geared more towards white women, right? Or just standards of beauty. You know, there's a lot of social buffering where Latino or you know, people of color, where they are not expected to react in the same way as white women. There is, and you know, people of color are underrepresented in the diagnosing and treatment of eating disorders. There's not a lot of research. There's not a lot, right? People of color that have eating disorders, they have less access to treatment, right? Whether it's their socioeconomic status, whether it's just, you know, the insurance, the cost, people having treatment in their language, right? There's a lot of barriers to treatment, to good treatment. And also, they're not really considered in, you know, the reasons that they develop eating disorder. There's racial stress, there's, you know, oppression. There are things that maybe can't be, it's not really in the literature as much. And so they're underrepresented population, but they make up a large population of eating disorders. So, you know, here I am, a white, you know, heteronormative cisgender woman. I'm the quintessential person that would be expected to have an eating disorder, and I did, and I went through training, and now I treat it, and I treat primarily people like myself, right? So I do have a client, a Black client from Barbados, and we talk about her binge eating disorder, and issues of racism comes up and how she feels with me as her therapist. And, you know, I'm very humble. I say, you know, I can't deny the problem here, right? And I think the solution is that, just like what you're doing, spreading awareness, involving this in the curriculum. Most people that treat eating disorders are people like myself, right? And that's not going to be the most welcoming experience for someone of color that wants to feel that, you know, their issues can be relatable or that it's going to be in their language. So, you know, it's a hard question for me to answer, but the truth is I'm very open and honest with my clients. Most of them are white females, right, with eating disorders. But in this one case, also, when I was in my training at CSAB, there was one woman of color that was a therapist, and it was very exciting for us because we know the need for diversity. And that's also a strange thing for someone to come in to the program and feel like, look at how happy they are that I'm here because I'm Black, right? So even that feels oppressive in a way, like maybe you only want me because I'm Black. Any Black client would go to her, right? So there's a lot of work that has to be done around this. A lot of research, a lot of work, and a lot of awareness, and you're doing it, right? But as far as with my clients, you know, the fact that I have had an eating disorder in the past, I don't disclose that to all my clients. I'm very careful if and when I ever do. But with this one client, I found that I wanted to, and I think I was trying to find some more relatability, right? That even though we might have developed eating disorders for different reasons, and you know, everyone's case is different, but like we're still all people, and I kind of get the cycles you're in, for her to feel more aligned with me. But the reason she chose me versus other therapists, she said, was that she felt that I was really professional and I really knew my stuff, and she had a good feeling that she thought I can help her. So, you know, it's just it's just a problem in this field.
Yeah. So other than like events like this, like bringing experts to talk to us, do you have any suggestions for how we can advocate for eating disorder awareness?
I love that you're going to be doing the NEDA walk. I don't know if there's room in the curriculum to add a course on eating disorders, but it would be really useful for people, not just in treating people, but a lot of people have eating disorders, friends and families, loved ones, right? It's just the psychoeducation we all need, I think, to be more privy, right? Or that signs and what to do. Sometimes there's a lot of people that are like, they're completely clueless of like, what's happening to me and what do I do and where do I go? What resources are available? But even if we can get, coursework about eating disorders into curriculums, it would maybe pique some people's interest to become specialists, and we can have more of a diversified counseling, right, profession about treating eating disorders versus more people like myself. Mm-hmm. But having being able to advertise for events and I don't know, fundraisers or whatever you can do to raise awareness. But having, if not a course on eating disorders, guest speakers or something like this, you're kind of already doing it, having me come and speak, is the advice I would give.
Yeah. Do you have any resources that you recommend to your clients or clinicians?
Certain books that I like, the one I talked about with intuitive eating is a big one that I recommend to both clinicians and really anyone, but clients especially. There are a number of people that actually do good advocacy through social media. It's not all bad, right? To help people in their daily lives. So I might have some people these are good people to follow to help you feel empowered in the treatment and healing of your eating disorder. There are some apps that are useful, right? There's meditation apps, there's journaling apps, there's eating disorder apps for the purpose of treating eating disorder and being a support to someone. There are also, helplines, and there's a lot of psychoeducation for friends and family. So if a loved one has an eating disorder and you don't know how to help, right? There are resources available for people to learn. And where I went for my training at CSAB, they had a weekly Wednesday night meeting for people to come in. It was an open house for educating loved ones, friends, family, significant others that are dealing with it in their house, to give them skills and awareness, right? There are books. There's the body image workbook that I use with a lot of my clients. There's Overcoming Binge Eating book, right? There's a lot of exercises and tools and things to think about in some of these books that are useful when I treat clients, and I might bring them in here and there. Yeah.
Awesome. All right, so we are almost to time. We have about 5 more minutes for, and then I'll do a little shout out to our walk that you mentioned. Does anyone else, you naturally answered the questions in the chat, but does anyone else have a question that they want to ask Maria? Feel free to unmute yourself or put your hand up.
I'll just go ahead and jump in. There was a question actually in the chat that I found really interesting from Susan, and she asks, eating disorder treatment has a reputation of being very challenging for the professional because they're difficult to treat. Do you think that's an accurate characterization?
I do. People, like I said, this is a longer term treatment. You have to allot a good 3 to 5 years, or at least that's setting the expectation for clients. Also, level of readiness. If someone is forced into treatment, folding their arms, resistant, it's not going to go anywhere, right? There'll be a lot of trying to tease apart their ambivalence right? So you could spend a year or two just doing that, trying to make sure they're medically stable. Part of the nature of anorexia is their denial of the seriousness of their disease. So it can be frustrating trying to convince someone that they're in danger when they keep waking up every day doing their patterns and they're like, look, I'm getting away with it. I'm kind of fine, right? So sometimes when people, on their own journey have to get to that point of readiness where it's from a place, an intrinsic place where they're like, all right, I want to have babies. I want fertility. I want there to be more to my life. I need to get, healed. I need to start the treatment on my own accord. So, resistance to treatment is huge, right? There's a intense fear of weight gain. A lot of times people know if I go for treatment, they're going to make me gain weight. And especially if someone is medically unstable or their body weight is too low and they're emaciated and malnourished, that's really the first step of treatment. Because guess what? Your brain doesn't work properly. I can't do psychotherapy with you if you're fainting, if you're dizzy, right? If you're lightheaded, if you're freezing, if you're have all of these physical repercussions. So, but then there's all the games. They go to the nutritionist, they drink 3 gallons of water before getting weighed, right? Just so that they look heavier and they think they get away with it. And they just keep shutting everyone up with, they okay the nutritionist to death about, yes, I'll do the treatment plan. And then the next week we talk about all the reasons they didn't. A year passes, right? So it's very gratifying to work with the client who's actually ready and is doing the work and is introspective and committed with 2 feet in by themselves. That's not the norm. And that's why it's not my full practice. I need a good 40% of people with other issues to remind me that I know what I'm doing.
Yeah. So would you say that it's better to refer someone with an eating disorder to a specialist rather than, a general counselor giving some worksheets or something like that?
Yes. Mm-hmm. And I've had people refer people to me for a number of sessions in addition to them working with their client about other issues. And, we've worked in tandem. I've done that a few times, but, the eating disorder doesn't go away after X amount of sessions. So it really is better for them to be in the right hands. Mm-hmm. And I have had someone treat an eating disorder. It was kind of a low-level eating disorder, someone kind of about to develop one, all the breeding ground in the teen years. And she asked if I can supervise her. And I agreed so that my eyes were also on the case to help her. And then also with the agreement that if it ever got past a certain point, because they had a good therapeutic alliance and she really didn't want to switch therapists, mm-hmm. that then she would need a different, counselor or a different level of care at a different point.
Mm-hmm. Amazing. Well, thank you so much. This was so incredibly insightful and obviously, as we mentioned, so needed for us as students. Before everyone signs off, Suni just put in the link. We are participating. We have a team for the NEDA Walk, the National Eating Disorders Association. And the walk is on May 14th. It's a Saturday. Takes place from 10 a.m. to 12 p.m. and it's here in Montclair, which is amazing. And so fortuitous that it is happening in Montclair. So we're very excited. We have a team. If you want to sign up, just put your contact information in this Google form that Suni just shared in the chat. There's no donation minimum or anything like that. There's no requirement in order to participate for the walk. So just put down your info, let me know if you're interested or if you want to register right away. I'll send you the information. We're very excited. It's going to be super fun and obviously for a good cause. Also, we, as I mentioned at the beginning, we have recorded this, so if you want to rewatch it, there was so much information. You can feel free to do that. Also share with friends, anyone in the program who hasn't been able to make it this morning, and subscribe to our YouTube channel. We are posting all of the panels that we've had so far and will have in the future. There's been amazing things that we've done and we want to share. So yeah, thank you so much, Maria. Is there anything, any last nuggets of wisdom you want to share? Or is there like your website that you want to plug or anything like that?
I can email it to you. Yeah, I'm not really tech savvy, but yeah, sure.
All right,
Yeah,
well, thank you
for
so
having me.
much.
It was an honor. Like I said, this is one of my, hot topics of life, and it's my passion. And it's not every day I get to, do this and talk to people about what I do and, what I feel is my, duty on earth. This is my life's work. So I love to do this. Thank you.
Well, thank you. It's been truly wonderful. Thank you so much.
Before we all log off, can we give Jenny and Maria